Okay, good afternoon, everybody. My name is Karen Bloor. I'm a Professor of Health Economics and Policy here at the University of York, and I'm the university's Research Champion for Health and Wellbeing. And it's a real pleasure to welcome you this afternoon, both those of us in the auditorium here at York and also people watching the live stream from, I believe, around the world. So welcome to today's WHO Centre for Global Health Histories seminar on mental health and inequalities. And I hope this afternoon we'll take a broad view of historical and persistent limitations of our knowledge of mental health and inequalities. We'll discuss how a new focus on public mental health can be implemented and what's known already on reducing inequalities and improving mental health. It's an honour to be welcoming three speakers this afternoon: Antonis Kousoulis, Gerardo Zavela, and Natalie Creary. I'll give you a few more details of those as we're going through. But first, it's a pleasure to welcome Antonis. Dr. Antonis Kousoulis is Director of Public Mental Health Research, Programmes and Policy Functions of the Mental Health Foundation. The Foundation works across England and Wales, and Antonis's previous roles include developing research data at the Department of Health and academic appointments at UCL, the Harvard School of Public Health, and Oxford University. And today, Dr. Kousoulis will share with us his ideas about a novel strategy for prevention of mental ill health. And thank you for coming to join us this afternoon.
Thank you. I'd like to talk a little bit about inequalities and mental health. And there is a lot of interest in mental health at the moment, and this is global. We see it around the world. But the response to that interest is very inconsistent. There is a lot of evidence on certain spaces. There's not a lot of evidence on other spaces. And how people respond to this evidence is through investments and policies and plans that are not following similar patterns. So one thing that I think is worth noting, and we just published as a Mental Health Foundation a big report on mental health and inequalities, is what is actually the evidence in this space? What does it say to us? What does it mean? And how can we use it? And also, it's not all about complaining, if you like, or making the case and making the point that there is inequality and there is, an equal distribution of risk. But it's also about what can be done. What are the areas where there is some evidence that we can take some action? So it's all about convincing, and it's all about influencing. Our vision of the foundation is for a world with good mental health for all, and to achieve that, we have to go beyond clinical services. We have to go beyond treating people in crisis, which is important, but we bring a focus on prevention. And we've done that for 70 years across the UK, bringing together research and the voice of experts by experience to innovate, develop new solutions, research, understand the causes of mental health problems, influence for policy change, and campaign at scale. So this is very much, when we talk about prevention, when we talk about inequalities, this is very much what public health is about, and my background is in public health. And this is a definition I like. Public health is what we build together as a society when we shape our communities so everyone can achieve optimal health. So this is a nice definition, but is this happening? Is this actually the case of how we're using public health resources globally? Actually, the way public health resources are distributed and the way that you see the investment in public health happening is that there's more investment in places where there is huge inequity in access to services. So it's not exactly doing that. And we are left with societies, communities, countries where we don't have equal opportunities to flourish. So this is part of what I want to talk to you about. What is the evidence in that space? How is risk distributed across different communities? Take a focus in what's happening in the UK, but also a lot of these will be applicable more broadly, and also what are the evidence for some interventions. We all have mental health. We all can experience mental health problems, no matter our walk of life or background. But, and this is a big one, the risk of mental ill health is not distributed equally. So this is the key point. I was doing a podcast recently and an interview recently, and I've had similar questions from people. So some people have asked me, so why are mental health problems? I think they're much more common in people who are rich, right? Or in people who live in more affluent settings. And I was taken aback a little bit because there's still a lot of misunderstandings. And we seem to assume that the stories that we hear are in the news sometimes are representative of what is actually happening in the real world. So this is hugely important. To talk about prevention, to talk about inequality and mental health at the societal level, we need to understand where do mental health problems start? Where does mental ill health originate? What are the causes? And there's a lot of reluctance to talk about causes in mental health. But broadly speaking, this is sort of an integrated model of how we look at mental health. It's the interaction between biology, our environment, the place where we live, work, spend a lot of our time in, and our experiences, the things that happen to us, essentially, as we go through life. And research shows that we are not born with a genetic deficiency. There is a genetic risk, there is a genetic predisposition, but it's how our biology, how our genes interplay with our experiences and circumstances that is what makes a difference. So beyond our genes, which play a very small part of defining our mental health is shaped by the social circumstances we find ourselves in. And this could include anything. I mean, these are sort of quite negative imagery in terms of violence and neighborhood deprivation and things like that, but also deeply personal experiences, the transitions that we go through life, the relationships that we have with others around us. To better understand inequality, I think the easiest definition and the one that is most striking is one around the social gradient. So it's a little bit of jargon in terms of our space, but social gradient in simple terms is that people who are less advantaged in terms of socioeconomic position have worse health and shorter lives than those who are more advantaged. And this is consistently found across all spaces, all studies, all kinds of mental health problems, all communities. It's quite a consistent finding. This is the latest study I saw, which was published a couple of months ago in the JAMA Psychiatry, which is the risk of experiencing schizophrenia for a child, depending on the income of their parents during their childhood. So with each step, with each drop in the level of income of the parent, you see an increased risk for schizophrenia for the child. And this is just one example. This is just the most recent that I could find. There are a lot of similar graphs when you look at depression, suicide, anxiety, different kinds of mental health problems. Another thing I've heard is, so the social gradient is all about accessing healthcare. It's all about accessing services, isn't it? Because if you don't have a lot of savings, if you don't have a lot of means, it means that you cannot access good care. Well, first of all, there are nations that have free healthcare at point of care, like the NHS, and we still see that social gradient. But it's not just about care. It's not just about health services. It's about the combination of factors, as we said, that shape our mental health. Not just how we access the health system, but also what are the risks that we are exposed to as individuals and as communities that we belong to. So there is this reluctance that we have found as we have been developing our strategy at the Mental Health Foundation, which was all about prevention and taking a public mental health approach. People, I find, don't want to talk about causes of mental health problems. They always want to talk about risk and protective factors. And there is always a discussion, I think, in health research about how causality is established and what does it mean. And in mental health, this is even a more active conversation around how protective factors interact with risk factors. Obviously, this is just a snapshot of a few factors that are relevant. There's a whole range of what is relevant for us. But even when we are able to talk about causes, So for example, let's say in some cases we would be able to say or identify a mental health problem, like a case of depression was caused because of an experience of trauma, or it was caused by a chronic sleep deprivation, or excessive stress, or an exposure to discrimination. We don't always ask the question, and that also applies to the public health community, but also to more broadly in people who are decision makers in terms of allocating resources. We don't always ask, so what is it that increases your risk of being a victim of trauma or experiencing a traumatic event? What is it that shapes the quality of your sleep? What is it that exposes you to significant stress over time? So the responses for all of these is that there are certain issues, there are certain causes, but these are largely shaped by the circumstances in which we are born, grow, live, and age. And these circumstances, they are more often than not in our control. And they are shaped in different ways, and they are different across different societies, communities, cities, and countries, but there tend to be some really shared characteristics of those. And the factors that you can see in terms of neighborhood deprivation, in terms of poverty, in terms of structural racism, in terms of approaches to funding, is essentially what change these circumstances, and they lead to essentially create these causes of the causes. So what's happening in our environment is these causes of our causes, and in turn these are shaped by the distribution of power, resources across our communities. So it's quite a complex picture. So this is where sometimes some of this reluctance is coming from in terms of defining causes and effects in mental ill health. But the reality is that this distribution of power resources create an unlevel playing field. For many people, it's a struggle. For many people, you have to try, we use a football analogy, to score against in a field that it's always against you. It's always up against you. So some benefit more than others. Not everyone has the same opportunity to flourish in life. So this is a definition of what inequality means in relation to our health. We create lives in our societies that are unattainable for many people. I will not go through statistics and data for each kind of inequality that exists. They are all available in our report, but they do range from education, from our personal resources, from things that include our identity, our relationships, the communities that we belong to, our physical health, disability experiences, our housing, our neighborhoods, access to transport. There's a huge range of different risks that are shaped as inequalities in our communities, and there is a lot of evidence in the most recent and best that we could find in that report that you can go through. But instead, what I want to talk to you in the few minutes I have left is what we know that can be done about those. And yes, to address inequality, you need political will, and you need commitment from research and practice. But what is quite important is to be able to create arguments that make sense, and create arguments that are based on the best available evidence. So this is our new visualization of what moving upstream means. So you have different levels of strategies and tactics that you can implement to prevent people from essentially falling down a waterfall, if you like. So on the one extreme end, you have crisis care, suicide support, and as you move upstream, you move into approaches that are policy-based and literacy-based. To implement these actions, I will highlight which are the ones that we found have the best evidence behind them. But to implement actions, we have to go back to a basic principle in public health, which is that of proportionate universalism. We suggest that, yes, you should take action for everyone. So you need to do something for everyone, which is the universal bit in that pyramid you see. But then you have to do a little bit more for people who are at more risk. And you have to do a little bit more for people who are experiencing distress or even higher risk or are in recovery. So actions must be universal, but the scale and intensity with which you invest in these has to be proportional to the level of disadvantage. So where is the evidence strongest? Investing in the assets and the strength that exists within communities. We have found that this makes a difference. We usually call it asset-based approaches, but it's not about reinventing the wheel. It's not about top-down approaches that bring an external perspective into communities, but it's about investing in what is already there in communities facing risk. And this also means working in equal partnership. That's the co-production element. So good evidence on how co-production helps shape communities. And if you go back to the initial definition of public health, shape communities where everyone can experience optimal health. Poverty is a big causal factor for mental health problems. So reducing poverty is important, but it's also what it means for action. Reducing poverty, there is evidence on interventions around debt relief, debt counseling, financial training. There is evidence around sort of income redistribution and taxation that seems to have made a difference in different settings. Housing is an important one. The neighborhoods that we grow up in, but also the actual homes that we own, or the homes that we live and spend a lot of our time in. There are trials like Housing First, which some of you may have heard, and other studies that show that as you improve housing conditions, mental health levels are improving as well. The evidence on having access to green and blue spaces is increasing. There is still more research done in this space, but when we compare differences of mental health levels in certain settings in rural areas and in similar socioeconomic conditions in urban areas, we see different levels of everyday well-being. And we know that the link between place and health in the big cities is very much broken. So part of it could be restored by increasing access to green and blue spaces. Trauma, another big factor for mental health problems. We know there is preventing trauma, preventing adversity in childhood would probably reduce all mental health problems by about a third. So protecting from trauma in many ways would be very beneficial, but we know that there's a long way to get to trauma prevention. So there is a lot of good evidence, and there are reviews happening at the time as well, international level, around trauma-informed approaches, trauma-informed services across all different settings, from schools to workplaces to healthcare services. Substance and alcohol misuse, obviously a lot of substance abuse starts usually as a result of a mental health problem, but so this is more on the tertiary prevention side of things. So it's where you can support long-term recovery, and we need quite a holistic approach in how we look at recovery from a mental health problem and supporting substance and alcohol misuse services, so quite joined up. And educational attainment, especially in ages around teenage years, again, a space where evidence exists that if you reduce that inequality there in terms of how many children drop out of school, and their mental health outcomes also really change. So again, there is space there. There is evidence around how schools should look into their exclusions policies and how they treat children who are have behavioral problems, and how they increase inclusion within the schools. We will be soon publishing, I want to give you a sneak peek of that, if you like, a new socio-ecological model of, in terms of this is in an urban mental health setting, which is redefining the whole community approach in a way. So it's about investing in the different aspects from a cultural perspective, an attitudes perspective, and services and psychologically informed spaces perspective across the whole community to achieve increased results, increased well-being for everyone. And I want to leave you with this. I think there is one of the problems about making the case. The evidence around inequality should be overwhelming by now. You know, we've studied these for years, we've understood these for years. It should be overwhelming. Everyone should be buying into that. If we reduce inequality, mental health is improving. But it's not the case. And I think one reason why this is not the case is that it's actually coming from us, from the research community. And a lot of the research, historically, but also to this day, we see an underrepresentation of historically mostly women, and these days minority communities within mental health research. So this has led to a relative lack of data on the experiences of mental health for such communities. And a lot of people with interest usually behind it confuse this relative lack of data with the actual very real experiences of disproportionate risk that certain communities are exposed to. So we need to start investing in some of these areas that seem to be working. At the same time, from a research community perspective, we need to start looking into the distribution of funding, the diversity in the funding bodies, where government is investing resources to start collecting more comprehensive and holistic data on the experience of mental ill health across the whole spectrum of everyone in the community. Thank you.
Thank you, Antonis. It was a great. Thank you for that fantastic talk, and looking forward to reading the report. And I think we'll take questions for Antonis and for all the other speakers at the end. We can have a small panel discussion if that's okay with everybody. So please hold your questions. I'm sure you have some, but note them down and we'll pick those up later. So next this afternoon, I'd like to welcome Dr. Gerardo Zavela, a research fellow here at the University of York in the Mental Health and Addictions Research Group. Gerardo has a PhD in public health epidemiology, focusing on the comorbidity of infectious diseases and nutrition in Mexico and Cuba. And he's presently working within the IMPACT program on comorbidity of mental and physical health in South Asia, which he is going to tell us more about this afternoon.
Yep. Yeah, thanks. No, that's not. It's here. Something's wrong with the. Here it is. That is great. So good afternoon, everyone. Today I'm very happy to be here and just present part of the great work that we have been doing here in York to address inequalities by improving mental and physical health. In this case, it's in South Asia, but as you will see throughout the presentation, we want to focus overall in low and middle income countries. So let's just start. When we speak about comorbidity of mental and physical health, we have two main problems. The first one is the physical health of people with severe mental illness, and the second one is mental health in people with long-term conditions. So I'm going to start with the physical health of people with severe mental illness. There's a big problem. So people with severe mental illness die on average 15 to 20 years earlier than the general population. So as we can see in this graph, the life expectancy have improved for both. So the red line is the general population, and the blue-green line is people with SMI. As we can see, the life expectancy is increasing, but actually the mortality gap, it's broadening in between the two groups. This graph is taken from a population in Australia, but actually a very similar trend can be seen in other high-income countries. What's interesting is that this gap might be even bigger in low and middle income countries. There's not a lot of evidence, but for example, there's a cohort study that found that people in rural Ethiopia with SMI or severe mental illness were dying 30 years younger than the general population. Also, what's important to say is that most of these deaths come from preventable or treatable physical conditions, such as obesity, hypertension, type 2 diabetes. So again, this graph, it's taken from information in the UK, because actually we're missing a lot of information in low and middle income countries. So as we can see, the prevalence of obesity and type 2 diabetes is double as much in people with SMI than the general population. And which are the causes for this? One of them is antipsychotic medication that increases the risk of these diseases. But many of these are preventable by, for example, increasing access to physical health, or by reducing health risk behaviors as an unhealthy diet, lack of physical activity, and smoking. The second problem that I'm going to tell you about is mental health in people with long-term conditions. I'm going to focus on diabetes because it's one of the most prevalent long-term conditions. So a systematic review that looked into the association between depression and diabetes found that the prevalence of depression was twice as much in people with type 2 diabetes than in the general population. At the moment, we are carrying on this research in a population-based sample from Mexico. And we found that after adjusting by different socioeconomic variables, the odds of having depression are 1.45 in people with type 2 diabetes as compared with people without diabetes. And the same trend can be seen in other long-term conditions. Also, something that I want to stress is when people have depression on top of the long-term condition, the health outcomes for both are worse. They have also worse quality of life, shorter life expectancy, and the healthcare utilization, it's bigger. And that's particularly important in countries where we have universal healthcare, because that's a big burden for the healthcare systems. And why is this important in low and middle income countries? It's mainly because the health systems are not as developed as in high income countries. So, for example, there's not an integration of physical and mental health in those. And actually, we can see that the prevalence of long-term conditions such as diabetes is increasing the most in these countries. So, for example, if we see at India, there's 69 million cases of or people with diabetes. So then I think we're in the right point where we can act and then try to generate evidence so we can move forward in this agenda. Then speaking about inequalities, as I told you before, there's a lot of efforts being done in high-income countries. Efforts as integrating physical health in people with severe mental illness, but also screening, treating, and preventing depression in people with physical long-term conditions. And these are some of the programs that are being done here at York. But there's also many other programs in the UK and other countries. But the picture is quite different for low and middle income countries, where we have additional challenges such as stigma, poverty. There's also less awareness of mental health, lower access to healthcare, and actually lifestyle interventions are almost non-existent. On top of that, we need to add that there's not enough information, there's not enough research being done, so then it's difficult to prioritize where to act. And all of this just further increase the inequalities in countries. So I think it's very important to see the inequalities in the country, but also there's a lot of inequalities within the countries. Just to try to help in these challenges, we created the Impact Group, and we're collaborating with different centers in Bangladesh, India, and Pakistan, and also with many universities in low and middle income countries, but also in the UK. I also want to stress that we're working with the main mental health institutions in the country, so we have strong collaboration with the National Institute of Mental Health in Bangladesh, with NIMHANS, that is the National Institute of Mental Health and Neurosciences in India, and also with the Institute of Psychiatry, that is a WHO collaborating center. And then this is basically the structure of the impact program. So we have 3 research projects. The first one is a survey in people with severe mental illness. So we can have more information on the main health conditions in people with this illness, but also which are the health risk behaviors that are contributing to this illness. Then we have a development of smoking cessation intervention for this population, but also in terms of common mental disorders, we are implementing a behavioral activation intervention for people with depression and long-term conditions. We also have a very strong capacity building work stream, because we believe that just promoting research capacity in these countries is going to promote further research, and then it's going to expand the possibilities, and it's going to reduce inequalities in these countries. And finally, we also have a health systems and policy work stream, where we're working with policymakers and stakeholders to increase the impact of the program, but also to make it easier to expand the interventions. So the long-term objectives of the program is to improve physical health in people with severe mental illness, to improve mental health in people with long-term conditions, and by addressing this, we believe that we're going to reduce inequalities in people with mental illness overall. With a last objective of adding years to life and life to years. So then, as I told you before, I'm going to use some of the time to go through one of the projects of impact. So the first one is actually we want to develop some evidence that is not existent in the moment on the prevalence of physical disorders and health risk behaviors in people with SMI in India, Pakistan, and Bangladesh. And to do this, we're going to carry on a survey. It's a cross-sectional study with 4,500 participants. Are adults diagnosed with SMI in mental health facilities in Pakistan, India, and Bangladesh. We're going to do a random selection of these participants. We're going to confirm the diagnosis of SMI, and those that are confirmed with SMI are going to continue with the survey. Over here we can see these are the main contours of the Institute of Psychiatry in Pakistan and of the Institute of Mental Health in Bangladesh. So we are collecting information on health-related quality of life, mental health outcomes as depression and anxiety, and we are using the WHO STEPS approach for addressing physical conditions such as diabetes, hypertension, and heart disease, and also using this same approach, we're gathering information on physical activity, diet, and tobacco use that are the main health risk behaviors of this population. In addition, we're taking information of healthcare utilization, and we're taking physical measurements just to get a sense if there's problems with nutritional status, and some blood samples to determine biological markers of long-term conditions. This is the team in Pakistan and in Bangladesh. So I also want to use this opportunity to congratulate all the effort that is being done in the countries. And I just want to point out that we're using remote data gathering system because actually the countries are not so used to this kind of data entry process. And it's a good way to promote reducing use of paper, but also to improving the outcomes in research. Then this is the progress so far. So the study has been set up in the 3 countries. We're more than halfway on Pakistan and Bangladesh. And we just started this month in India. And then I'm just going to share some of the preliminary results. So as you can see, this is the prevalence of underweight, overweight, and obesity in Pakistan and Bangladesh. So the blue triangle is the prevalence of underweight. So we can see how we have a double burden of malnutrition, with a problem of underweight, but also around 50% of overweight and obesity in this population. In Pakistan, the problem is similar. Then I'm going to continue with some of the health risk behaviors. So this is smoking. At the beginning, we believed that this was going to be a much bigger problem, but actually the rates of smoking in males is similar to the one of the general population. And the same happens for females, where it's not so common because of the social perception of smoking in the countries. Finally, I'm just going to show this graph of the prevalence of diabetes. So the blue bar, it's the people that have been tested for diabetes. So actually this is already striving a result, because it's good practice when a person has a severe mental illness to test them for diabetes. And only 35% of these patients in Pakistan have been tested for diabetes. And in Bangladesh, it's way worse, where only 20% of these patients have been tested for diabetes. Of those that have been tested, in Pakistan, 22% are diagnosed with diabetes, and almost 50% in Bangladesh. So then I'm just going to finish with what's next in terms of this part of the study. So first of all, we want to expand to have a national survey. We're already recruiting new sites in Pakistan, and we're looking for new sites in Bangladesh and in India. We also want to expand to other low and middle income countries, because we know that the social contexts are different, but very similar at the same time. So we want to carry on this methodology that we already implemented to different countries. Also, we're going to use all the information that we gather to make the tailored interventions, such as Impact 4S, that is an intervention for smoking cessation, where we already use the information that we gathered for the survey to make it more appropriate for these people. Also, we want to explore, since we saw a big burden of a double burden of nutrition, where we saw people that were underweight, but also a lot of people with overweight and obesity. We want to explore the nutritional challenges in the population and see how we can address those in order to improve mental and physical health. We also want to create a cohort study so we can evaluate what's going on with the population over time. And finally, these results are going to help to steer policy. So we're going to present policy reports to present to stakeholders and policymakers in the countries, so they can start implementing policy in terms of the main diseases that this population have, but also the main health risk behaviors that they're engaging with. So I just want to end up thanking the whole Impact team and all the hard work that they have just put into this project. And yeah, thank you very much.
Thank you, Gerardo. And what a cheery bunch they look, actually, the Impact team.
It's a great team.
Good team, good photograph. Thank you for a really interesting talk on a hugely ambitious and exciting project. So, as I said, we're taking questions at the end, so please take some notes of those. And in the meantime, let me introduce our third and final speaker this afternoon. Natalie Creary is Programme Director for Black Thrive, an organisation set up in the borough of Lambeth in London to bring together everyone interested in addressing issues surrounding mental health for Black people. And before joining Black Thrive, Natalie worked at the Health Foundation and as a lecturer at the University of East London, and on a range of cross-sector community partnerships to address health inequalities. So thank you for coming, Natalie. Welcome to York. Are you okay to sort this off? Yes.
Well, thank you very much for inviting me. It's a great pleasure to have the opportunity to share with you some of the work that we are doing in Lambeth. So let's start. So what I thought I'd do is I would share, give you a brief overview of what we do at Black Thrive, and kind of how we came about, to share with you how we integrate the work around social determinants in relation to our approach to systems change, and to explore how racism should be perceived as a public health issue, and then also to share some of the reflections on our learning through this journey in terms of trying to improve the mental health outcomes for Black people in Lambeth. So Black Thrive is a partnership between statutory organisations, local communities and the voluntary sector, and our work is underpinned by a collective impact model. And the premise behind that is that we are trying to ensure that our agendas are aligned, that we focus our resources and our energies to tackling the root causes of mental health inequality for Black people in Lambeth. And to help us do that, we have what we call a shared measurement system, which is using local data to help us understand the outcomes for Black people in different services. So we're currently pulling data from the criminal justice system, housing, the education system, to kind of understand what that looks like for Black people locally. And then what we're also aiming to do is improve people's access to services whilst they have contact with the mental health system, ensuring that they have a better experience of mental health services, but also focusing on prevention, because Black people are more likely to enter the mental health system through more coercive routes, and also have poorer experiences and general outcomes. So when we think about racism, I think through our work what we've realised is that people generally have quite a narrow understanding of racism. And so the first thing that comes to their mind is around personally mediated racism. So, you know, somebody treating you either consciously or unconsciously differently, or, you know, or providing worse treatment to you because of your race. And to some extent, we do see that the treatment of Black bodies, there is a differential experience for Black people. And we see that in terms of detentions under the Mental Health Act. Black people are more likely to be restrained and secluded. And we also find that there are issues around kind of higher rates of mortality for people from Black backgrounds. And one of the things why we kind of really need to think about this is that people's experiences of racism actually has an impact on their utilisation of services. So if we're thinking about early intervention, that plays quite an important role in terms of addressing that. And whilst we tend to focus on the kind of interpersonal level when it comes to racism, we also need to pay attention to all forms, both in terms of internalised racism and institutional racism, because they all reinforce one another. So if we're thinking about, and Antonis referred to this earlier, that if we're thinking about healthcare, our contact and our access to healthcare, only accounts for probably about 10% of our overall health outcomes. So we need to be thinking much more broadly than just the healthcare system. And almost to some extent, by the time somebody is accessing the system, you know, we've obviously missed plenty of opportunities in terms of prevention. And so we really need to start thinking about the social determinants of health. And this in part is what we try to do at Black Thrive when we're looking at the data more broadly than the health system, looking at housing, looking at employability. And what we find is that I think sometimes we become sidetracked even by these factors without really thinking about how racism and other forms of oppression actually shapes those outcomes. And by not doing that, it also means that the interventions that we decide to invest in also neglect that. So, for example, if we look at unemployment rates among Black communities in Lambeth, we have, you know, Black people have higher rates of unemployment. So the solution to that may be, well, let's get people jobs. But actually, if we're not really kind of unpicking this in terms of Black people experience significant barriers to accessing employment, once they're in employment, they're more likely to be subjected to microaggressions, disciplinary procedures are more likely to be escalated. So whilst you might get somebody a job, you're not fundamentally creating those conditions in which they can thrive. And so for us, when we're looking at the inequality that Black people experience, it's also paying attention to the different systems of oppression that lead to the inequality that we're currently observing. So in terms of when we're starting to think about racism as a public health issue, we know that there are physical and emotional consequences in terms of experiencing racism and other forms of discrimination, and in particular around this concept of weathering, that the ongoing exposure to stressors is actually accelerating the ageing process for Black people. And there's an increasing evidence base that discrimination is a risk factor for ill health. But what's quite interesting, when we look at the literature, it's relatively silent on racism in terms of the physical and mental health outcomes of communities that experience the poorest health outcomes. So in our work at Black Thrive, we pay attention to race and racism. And what we find, as I said earlier, that people tend to have quite a narrow understanding of what racism is and how it operates. And by virtue of not understanding that, it means that we have the inability then to respond in a way that's actually going to reduce the inequality that we observe. We find that people refuse or avoid having these conversations, which provides, it just acts as a blockage to the progress that we'd like to make, and in some circumstances sabotages, the work that we are trying to move forward with. I think that there is something, there's a great focus on the evidence base, that things that we do must be evidence based. Let's go to the literature to understand what we need to do. And I think that, on the surface, that appears to be a rational thing to do. But actually what we're not necessarily paying enough attention to is the inherent bias within the literature. We very rarely question who is producing this knowledge and what is the politics of the researcher who is undertaking this research, or the agendas of the funders who are funding it. In terms of being data-driven and data-informed, within our work there is also that tension. And so for us, we think it's really important to be data-informed. When we're data-driven, what we realise within in our work and the indicators that we are looking at, that they are often defined by somebody else's agenda. So we're collecting that data in order to report to central government or to some body, and that may not necessarily be the things that are of interest to communities or what's important to communities. And also the quantitative data only tells you one side of the story, so it doesn't provide the context for you to really understand what's going on. So again, what's really important for us is that communities are kind of part of that conversation. Another issue that we tend to, or that we've come across, is data suppression. So when providers are aware that the picture doesn't look very good, that there is the reluctance to release that data. But by virtue of not sharing that, it means that we don't have an understanding of where we need to focus our energies in terms of trying to improve the situation for Black communities locally. I think there is something about how we frame the issue. And I think that, I sit in lots of presentations where people share really kind of shocking statistics about the experiences of, Black people, the outcomes of Black people, and it serves the purpose of, making the audience feel shocked. They may gasp, and in some respects it's a little bit misguided that we think by virtue of generating that reaction from the audience that it will perhaps drive them to deliver change. I think what we don't necessarily always think about is how that information is received and how that is interpreted. In particular, how what you say may in fact reinforce stereotypes, reinforce those assumptions. So when we are sharing data, we need to be mindful of the context, and kind of sharing data without context is, it's irresponsible. In terms of the other reflections that we have, is that there appears to be a preoccupation with individual level intervention, and in terms of people's health behaviours, because what that does is it then situates the problem with the individual. And if we're thinking about upstream and downstream factors, actually we probably need to spend a bit more attention focusing on the structural issues to prevent people from becoming ill in the first place. In terms of the overemphasis on the biomedical model means that there is very little space for social models of mental health. And, you know, for us, we feel that it's kind of really important that, you know, that there is the opportunity for that. There is this ongoing tension in terms of who is the expert in this space. You know, is it the person who has been researching the topic for years or the person who's been living with it? And that's something that we try to balance within our work in terms of respecting the perspectives of all who are involved. But I think one of our kind of observations is that we find that at times people want to run, you know, with this in terms of, you know, moving forward with the mental health agenda. And, you know, on first inspection, that seems like a great thing that, you know, people want to pick up the mantle and, you know, make a difference with Black people. But some of the challenges that arise from that is that we are expected to kind of work with them on their terms. How that manifests itself in terms of Black people not necessarily having the opportunities to shape the agenda or the narrative that surrounds the work, that they often have the monopoly on the resources that follows the work. So what's really important is that the voice of communities needs to be embedded, but actually that involvement shouldn't be tokenistic, that actually they should be seen as equal partners, and their experience of working with us should also reflect that. And I think there is also, in terms of the distribution of power, we talk about the distribution of power, but I think that it's not necessarily really understood in terms of how that actually plays out in the interactions between individuals, in teams, across teams, with organisations and communities. So, based on my reflections, what do we need to do? Everything that's not on the other list, basically. I think it doesn't matter how uncomfortable having conversations about race and racism is. It's absolutely imperative that we have these conversations, because without it, we're only really looking at part of the picture, and any kind of intervention or policy that we try to develop really isn't going to deliver what we are kind of hoping that it will. In terms of when we're looking at the literature, you know, we need to critique it from a structural and a cultural perspective to really understand, you know, the worldviews of those that are producing the knowledge, and you know, the extent to which people from those communities have been involved in the sense-making of that data. Because often we extract the data, we analyse it, and we present it. And I think that there is value in involving communities in all parts of the knowledge production process. I've kind of talked about being data-informed, that actually it's important that you also have that qualitative data to help you really understand what it's telling you, because we all have our own worldviews, and we will come with our own assumptions about what that is telling us. I think we need to move away from kind of just describing the problem, but actually moving towards action, like what is the solution. I don't think I need to read another paper that tells me how bad it is for Black people. What I would like to see more in the literature is the experiences of Black people in terms of their experiences of services, the experiences of you know, life more broadly in terms of, you know, when we're thinking about the social determinants of health. And I think that we need to think and act within systems. So rather than just focusing solely on one particular aspect, really having that understanding of how that interlinks with everything else. And we also need to make sure that we are focusing our attentions on communities and ensuring that their voices are at the centre of everything that we do. But also recognising that communities are not a homogenous group, and that any kind of work, research, anything that we design is actually really taking an intersectional approach so that we can really understand how people's social identities intersect and how that then plays out in their experiences of health and well-being. And I think we also need to become more sophisticated in our negotiations around power, and being really open and honest about how that plays out in our work, in our interactions with one another. And I think if we manage to do most of that, I think we will be sort of well on our way to actually kind of delivering and achieving the step change that we're all working towards. That's me.
Thank you, Natalie, and thank you all three speakers this afternoon. Can I ask you to come up to the front, and we'll is that okay with? Yeah, okay. Please, and you're all mic'd up, and we've got several minutes here for some questions and discussion in the room, and apologies that we can't have discussion from around the world as well, but that would be nice. Maybe we should find a way of doing that sometime.
That's the next reform.
Yeah, next iteration. Within the room, can I ask that you wait for a microphone as well and tell us who you are, if you like to, please.
Hi, thank you. Now better?
Yes, perfect.
Yeah. Hi, thank you. Hi, well, obviously my question is not from a global health perspective because that's not my area of expertise. I'm more on patient engagement and patient involvement, and I'm trying to think on the global perspective, how much you involve and who is actually who you need to involve in this process when designing this type of studies, either from the survey or just kind of policy research or even an intervention. Is it the patient that you should be involving, or is it the community, or both? Because as you mentioned, otherwise it's just driven by the research. And if what you are saying that there is actually lack of evidence coming from these communities, then we're just translating what we have learned from totally opposite scenarios and just hoping that what worked there or what these findings show us will straightforward work there. And it's, I think, a very big investment that can be missed if it's not properly driven, no?
Yeah. Should start perhaps.
Okay. Well, I always say it depends what you're trying to achieve. But I think that it's important, I think, to try and involve people in all parts of the process. So if you're trying to develop an intervention that's targeted at patients, it would make sense to involve those patients in that process. If you're trying to design something that is kind of more broad, it's kind of something that's kind of more general or more universal, then you may look to involve people, more broadly. I think one of the challenges is that, and reflections even within our work, is the pace that we want to work, which doesn't necessarily lend itself to involving communities in a meaningful way. And so it almost becomes a bit of a tick box exercise. So I think it's something that we need to make sure that we have, you have to plan that in, and it will always take longer than you think it will.
And I think something that Natalie and others do really well is involving from a really early stage. So it's not, I've designed the idea, I've asked the research question, and now let's consult a few people, but it's also let's shape the questions from the start. And from my perspective, this is an important point in terms of, we usually say patient involvement, patient and public involvement, and we want to involve and include people with lived experience in what we do, but it's how we define that lived experience. And sometimes, and in this case of our theme today, is a lived experience of inequality, could mean a range of different things, but it's there. Just one point I want to add is that we talk about hard to engage communities, hard to reach communities, which I really hate as a term, so I just want to record that. It's about seldom engaged communities. We are not engaged in the community. It's not that they are not there to reach them. So it's shifting again the power dynamic in terms of how we have the conversation.
Yeah. If I may add just to this, in terms of global health, I think it's very important to see it in a holistic way, where we have data to know which are the main problems, and then acting on those problems. So, for example, in impact, it's the research that I'm involved now. So first we did the survey when we saw that smoking was one of the biggest problems for this population. And then to develop the intervention from the very start, we approached patients. And actually, I think these communities, they have been so neglected that whenever you bring some attention, they're very receptive. So it was amazing the engagement that we had from patients, but also from the carers. So they really wanted to be involved in every single community panel that we had. And then actually they were the ones that were steering the intervention. So I think seeing it as an holistic approach when you have the data, and then how can you use that data and use the patients to just do a more holistic approach. Yeah.
Thank you. Sure.
I'm really impressed with the impact study and the results. Since you want to take those results to the policy level, I thought to ask this question. Since the mental health issues led to long-term conditions, so have you done any sort of a root cause analysis to find what are the real causes for this? Since the policy level is looking at the investment and they are really looking for the opportunity cost as well. And except the generic areas, what Antonis mentioned about the education, housing, and employment, have you found any other causes for the mental health issues leading to the long-term conditions? And meantime, this is another question. In that type of clinic, have you found anybody from the long-term condition ended up in mental health issues? Really, it's really somebody with diabetes or hypertension, or they must have ended up in some sort of mental health issues. So how do you look at these two issues?
Yeah, so I can start first with, first in terms of the policy and the cost. We haven't reached that far, so at the moment we're doing a policy analysis just to look out for all the policy documents that are in the countries. We are starting in Pakistan as an exercise. So then we extracted all the documents, and then we're just going through them with a framework to see what's there and in which way both mental and physical health are integrated. And I think just the next step, it's going to the actual cost and see which is the added cost of mental health when they have a long-term condition. And can I just ask you again about the last question about?
Now it's a mental health clinic, I suppose.
Yeah.
So the usual causes for the mental health person with mental health issue ended up in long-term conditions. So there's another possibility, long-term condition ended up in mental health issues.
Yeah, and actually that's a very good question, and there's a lot of research done in the causality of these two conditions. In many cases, the long-term condition causes mental health problems, so when a diagnosis is given, and I think the risk ratio for that is lower than the other way around, where when you have depression, then that involves a lot of problems in terms of lifestyle. So usually people don't go out as much, they reduce their physical activity, their diet reduces. And according to the evidence, that link is even stronger than the other way around. So I think that's something that we need to consider while we analyze all this information in terms of long-term condition and depression. So yeah, thanks. I don't know if you...
Yeah, I mean, in terms of how physical health conditions cause long-term mental health problems, I think some of the mechanisms also include some are economic, so and financial. So people are often paying a lot for their care, and they end up in debt or in any other financial hardship. And it's also about, quite often we find about relationships, because a long-term problem can be quite isolating. And this certainly impacts on people's well-being. So just two mechanisms. I think so.
Thank you. Any other questions from the room? Yes, please, Sanjoy.
I was fascinated with your reference to intersectionality. So I'm thinking here about the double whammy of race and gender. So how does that pan out in what you studied and what you do? Does it pose specific challenges, specific solutions?
I think one of the things with intersectionality is that I think there is often that perception that if you are black and female, or that if you identify with more than one marginalised identity, that you're going to experience disadvantage in all spaces. It's far more flexible than that. So, for example, I'm a black woman from a working class background, but actually by virtue of my education, it means that I now have access to middle class spaces. So if I'm going around the supermarket, yes, being black isn't helpful because I will be followed around the shop, but I will experience those stresses in those situations. But then in other spaces, I don't. So I think it's I think the most important thing is to work out where the person is at, I guess, because again, people are not necessarily always aware of the discriminations that they experience. So in particular in my research, people will never even speak of the word racism, but actually if you listen to their narrative, almost, and they tell you their life story, it speaks to structural isms, not necessarily just racism. And so for some marginalised communities, actually racism and other forms of discrimination have been internalised to the point that we don't actually even necessarily realise it, because we just get on with it because it is the way it is. But I think it's important for us, if we are undertaking research, that we are being mindful of that and paying attention to that, in particular around our interpretation of people's experiences, that is in mind.
Can I ask a question? I've been struck by, Centre for Global Health Histories obviously takes a historical approach to health, and we've been talking today about some long-established and pretty persistent inequalities. And I just wondered how you think now differs from previous times, previous decades, and how we can perhaps enhance, sort of harness some of the new things about now, like the communication and the fact that we can talk to people in I don't know, where are we, Copenhagen and India and around the world. How can we harness some of the things that are new about today to address some of these long-established and persistent inequalities better? What can we do? What can we do better?
I think my issue at the moment is that we seem to be doing worse, and or at least we're not doing better, which is also really bad. And I think obviously mental health data are not always the best quality, especially if you go back a few decades. But if you look at the biggest, trends and the databases that collect a lot of sort of these trends over time, you see a lot of the physical health conditions. You see the things going down, like child mortality and cardiovascular issues and things like that. And you look at the mental health lines, and they're all like this. They've all stayed the same. Yeah. So, in a way, maybe some of these are not worse, although some probably are. But it's actually worse because they haven't really reduced. And
yes.
And I think this is a huge inequality from my perspective, in that it seems to be unacceptable in any other area of health that these rates, would stay stable or increase for over decades. But in mental health, we sort of accepted it.
Yeah.
So I think there is probably a lot of innovation. Maybe, Black Thrive is an example of bringing together community towards better outcomes. which maybe was not done as well in the past as in similarly organized ways in other settings. But I think I'm not entirely convinced that a lot of our new methods of communication or whatever else, new products or whatever else have actually are here to play a positive role. Maybe I'm too pessimistic, I don't know.
Yeah, that was quite a gloomy answer. Fair enough.
I think in terms of the advancements in technology have strengths and there are strengths and weaknesses to that. I think one of the positive things in terms of kind of communication is that we have that ability to communicate with people that we perhaps wouldn't necessarily engage with otherwise. So I think that's important in terms of being able to share ideas and sharing good practice. I think what we're doing today, I think, is an example of that. Because if I was in my office in Lambeth, whoever is on the webinar right now wouldn't have heard about the work that we're doing. So I think that's definitely an important part. I think with technology, I guess when we're thinking about race and racism, again, it highlights other issues in terms of where there is the underrepresentation of people from marginalised backgrounds. Actually, these developments are also excluding them from that process. So again, we need to make sure that we are being inclusive in the development of technologies, so that we don't find other ways of kind of recreating or reinforcing the inequalities that we observe.
Okay, thank you. Any more questions from around the room? Yes, here. Thank you.
I just want to ask us regarding support for mental health, especially in the UK here. I want to ask two questions. And as at 20 to 30 years ago, the mental health charities in the UK was actually a lot. But when you look at the mental health charities that we have now, I don't think they're up to 5. We have like Mind, which is a very big one. So there is a real reduction in mental health charity. So I want to ask, why is there a reduction in mental health charities in the UK? Is it an increase in stigma? Is it a lack of awareness? Because when you compare to other charities like cancer, people are really, really fundraising for charities. So why is that? I mean, for mental health charity, why is there a reduction in it? And the second question I want to ask is the relevance between mental health and spirituality. Like, for instance, South London mostly, they are emphasizing more on mental and spiritual care. And especially in UK prisons, I think psychiatrists in UK prisons, sometimes they have to engage with the chaplains to actually support the mental health of prisoners. So just want to ask, because none of you make mention to spirituality, so is there a link between mental health and spirituality? Because sometimes the psychiatric nurses tell you that sometimes they do everything to support, but it's not really helping, and they have to work in hand with chaplains, same thing in the mosque. So I would just be, if you could just talk about that.
Okay, Antonis, can I come to you first on the charities and whether there are fewer of them or consolidated or whatever?
Sure. I'm not sure that there is a big reduction compared to 20 or 30 years ago. But you may be right, but if there is indeed one, I think if we look at funding levels, they have probably increased only recently, maybe in the past 2 years or so, in the UK at least, for the mental health non-governmental sort of sector. And perhaps one interpretation, if that's indeed true, is that what I see when you look at local community level across the UK is that a lot of the mental health work is done by local grassroots organizations, which are not called mental health, charities or organizations or whatever, but they are the ones that do actually a lot of the local engagement and community development and, these asset-based approaches and things like that. So and they're not necessarily mental health charities, they are sort of local grassroots charities. So maybe that could be one explanation. I know a lot of the funding by some of the national funders, not a lot, but proportion of the funding would go maybe to some of these organizations, and it wouldn't be called mental health funding. It would be called maybe community development funding or whatever else. But because of how relevant mental health is to everything within our communities, it is actually, a lot of this, it is actually work for mental health. So it's an interesting, I'll have to check the trends over decades, but I think that would be maybe one interpretation.
Thank you. And who wants to have a go at spirituality and mental health?
Well, I think the main problem with the spirituality is how do we measure spirituality? Because I went to a seminar a few months ago, and they just explained, they wanted to see the relationship between mental health and spirituality in people in jail in South America, actually. And then the main problem that they came with is how do you really measure spirituality? Because you have, first of all, different kind of religions, people believe in different things. So actually having a measurement of that was the main issue in that research. So yeah, that's all I can say.
But I guess being part of a community, whether it's a religious community or a different kind of community, is perhaps one of the protective
It tends to be
factors.
protective, from that perspective. And also engaging with people who have influence within religious communities is also quite a useful way of not having top-down approaches, but letting sort of communities, co-produce what they would say work for them. So from this perspective, religious communities that share that kind of characteristic.
Yeah, and I think spirituality, can be important for people, when spirituality is important to you. And so, and I think that's also something that we also kind of need to bear in mind. And I think that's where there's the importance of having kind of services that are culturally appropriate, so that they're actually responding to people's needs. And I think if we think about if we just kind of treat people from a medical perspective, if your spirituality is an important part of your kind of recovery process, to completely ignore that is probably going to be very unhelpful. But we also kind of have to also be mindful of sometimes some of the tensions around kind of spirituality and faith, and in particular where there are misunderstandings of kind of mental health and how it manifests itself, or depending on your social identities, maybe in conflict with the faith that you have been, raised to follow. So I think spirituality is important, but we also need to be mindful that it plays a different role for different people in their lives.
Thank you. Okay, well, unless there's any more questions or comments from around the room, I think it's probably time to wrap us up. And I'd like to first of all thank you all for joining us. Thank you for those of us joining us on live stream from around the world. Thank you in the audience for being here on a Friday afternoon in York. And a particular thanks to our excellent three speakers for some really fascinating talks.
And thank you, Karen.